Welcome back to the deep dive. You know how this works, right?
Yeah.
Someone sends us a stack of medical papers or notes or whatever.
Oh, we dive in.
Yeah, we take a deep dive into it. And this time,
Looks like we're heading into the OR.
yep, all about intravenous anesthetics.
That's right.
You guys sent over a ton of pharmacology notes and articles, so someone's gearing up for some serious action.
Definitely getting ready for something.
Yeah.
And we're going to make sure they're ready by breaking down the must-know facts about these drugs.
Right.
From the old school ones like barbiturates to the newer stuff like Fospropofol.
All right, so before we get into the specifics like usual,
Yeah.
let's set the stage a little bit. What exactly are intravenous anesthetics and why are they so important?
Well, intravenous anesthetics are drugs that we give directly into the bloodstream to produce a rapid loss of consciousness.
So,
They're essential for modern anesthesia. They let us do surgery and other procedures
right.
safely and effectively.
So it's kind of wild when you think about it. We can just like put someone's consciousness on pause while we work on their body.
Yeah, it's like hitting the sleep button on their brain.
Yeah, exactly.
Yeah,
But it's not just about inducing sleep, right? There's more to it than that.
more to it than that.
You know,
For sure.
pain relief,
Yeah, you need pain relief.
muscle relaxation,
Muscle relaxation.
amnesia,
Absolutely amnesia.
you know, all these things.
All essential for a smooth surgical experience.
Yeah, so it's like this
Yeah.
multi-pronged approach
A multi-pronged approach.
to creating this ideal condition for surgery.
Yep.
But with so many different intravenous anesthetics out there,
Right.
how do we know which one to use?
Yeah, how do you pick the right tool from that giant toolbox?
Yeah, it's like having a giant toolbox. You're like,
So many
I
options.
don't even know where to start.
Yeah. Well, choosing the right anesthetic,
Yeah.
that is crucial. And it all depends on a variety of factors. You know, the patient's medical history, the type of surgery, and how long you want the anesthesia to last.
Yeah, so it's not just one size fits all.
Definitely not.
Okay, that makes sense. Let's dive into the different classes, starting with the barbiturates.
All right.
These are some of the oldest drugs we have, right?
Yeah, they've been around for a while.
Like thiopental.
Like thiopental.
They've stood the test of time.
Yeah.
How do they actually work? What's the secret to how they knock people out?
All right, so barbiturates work by depressing the reticular activating system,
Okay.
which is the part of the brain that keeps us awake and alert.
Okay, so they basically hit the off switch
They hit the off switch,
on consciousness.
and they also enhance the effects of GABA,
GABA.
which is a neurotransmitter that inhibits nerve activity.
Yeah. The brain's chill pill. So the barbiturates are like
Yeah.
double agents,
They're like double agent.
hitting the off switch on consciousness in two different ways.
Exactly.
That's pretty sneaky.
It is.
But while they're effective, they also come with some potential downsides.
Of course.
One of the key things is this context-sensitive halftime.
Yeah. You
Yeah.
got to keep that in mind.
That sounds a little complicated.
Well, it basically means that
Yeah.
the longer a barbiturate is infused,
Okay.
the longer it takes for the body to clear it.
Okay.
So if you keep giving those doses,
Right.
it can lead to prolonged sedation.
Oh, wow. So it's like a snowball effect.
Kind of like a snowball, yeah.
You know, the more you use, the longer it sticks around.
Exactly. And that's something to watch out for, especially during those long surgeries.
Absolutely, especially those long surgeries.
Yeah.
You got to keep that in mind. Another important thing to think about is
Right.
their effect on the cardiovascular system.
Yes.
What do they do?
So they can cause a drop in blood pressure,
Oh,
which can be an issue in patients that are already hemodynamically unstable.
so they're not the best choice for patients with heart issues or low blood pressure.
If you can avoid it, yeah.
Right. Okay. And speaking of organs, we need to talk about the brain too.
Of course, the brain.
My notes mentioned something about barbiturates and intracranial pressure.
Okay.
What's the deal with that?
So they can actually lower intracranial pressure,
Yeah.
which can be helpful in some neurosurgical cases
Oh.
where swelling in the brain is a concern.
So it's like a pressure valve.
Yeah, like a pressure valve for the brain.
Okay, but I have to ask this.
Yeah.
Your notes mention a garlic or onion taste with thiopental.
Oh, yeah.
Is that for real?
It is. Yeah, some patients report that.
What?
Yeah, peculiar side effect.
Why?
We don't really know why it happens,
Oh,
but it does.
that's so weird. And speaking of strange side effects,
Yeah.
porphyria.
We got to mention porphyria.
What's that?
So barbiturates can trigger attacks in susceptible patients.
Okay.
So something to keep in mind.
Wow, garlic breath and a porphyria.
Two things to remember about barbiturates.
Two things to remember. Okay, let's move on to another class. Benzodiazepines.
All right, benzodiazepines.
These are drugs like
Midazolam.
diazepam.
Diazepam.
Okay.
Yeah.
Those are the big
So
ones.
how do they work?
So like barbiturates?
They enhance the effects of GABA.
Oh, what other GABA fan?
Yeah.
Okay.
But they do it in a slightly different way.
Interesting.
They increase the frequency of chloride channel openings,
Okay.
which leads to stronger inhibition of nerve cells.
So they're like GABA's hype man.
They're like the height.
You're like amping up the chill out effect.
Exactly.
But what's great is they have an antidote, right?
That's right.
Flumazenil.
Flumazenil can reverse the effects.
If needed. If needed.
That's good to know.
Very good to know.
Just in case.
Just in case.
But like all drugs, they
Right.
come with their own quirks.
Yeah.
What do we have to be aware of?
Yeah. What do we got to watch out for?
You know, in terms of how they're metabolized?
Okay.
Now they're eliminated?
So benzodiazepines
Yeah.
vary widely in their duration of action.
Oh, okay.
Like diazepam
Yeah.
is notorious for its long half-life.
How long are we talking?
30 hours.
Whoa.
Yeah.
That's a long time.
It can stick around in the body for a while.
Wow. Okay.
Now, midazolam, on the other hand,
Yeah.
much shorter acting.
Okay.
2-hour half-life.
Okay. So diazepam's the marathon runner.
Marathon runner.
Midazolam's the sprinter.
It's a sprinter.
Makes sense.
Big
Then azolam's better for those procedures where you want
Yeah.
a faster recovery.
Faster recovery.
Yeah.
And another thing,
Yeah.
diazepam and lorazepam,
Okay.
they're dissolved in propylene glycol,
Okay.
which can irritate the veins when you inject it.
Ouch.
Not a fun time for the patient.
Yeah. Definitely something to keep in mind. So what else do we need to know about benzodiazepines in the OR?
Well, one of the most important things
Yeah.
is that they can depress breathing,
Oh.
especially when combined with other CNS depressants
Like
opioids.
Okay.
So careful titration
Yeah.
is essential.
Right. We don't want anyone stopping breathing on our watch.
Exactly.
But aside from the respiratory effects, are there any other advantages?
Yes, there are.
Like what?
Here's a clinical pearl for you.
Okay.
They can reduce the amount of volatile anesthetic needed
Oh.
during surgery,
By how much?
up to 30% less.
Whoa, that's a lot.
It is.
Wow, that's pretty significant. So they're making the volatile anesthetics work better.
Yeah, more efficiently.
Yeah.
Exactly.
Okay, let's move on to one that's a bit more unique.
Right.
Ketamine.
The one.
The one that can take you on a psychedelic trip while you're getting your wisdom teeth pulled.
That's right.
What's up with that one?
Ketamine is fascinating
Yeah.
because it produces what we call dissociative anesthesia.
Okay.
It's different from other anesthetics,
Interesting.
where the patient isn't fully unconscious.
Okay.
They're disconnected from their surroundings.
Yeah.
They might experience hallucinations, but they're still breathing on their own.
Oh, wow. So they're just in their own little world.
In their own little world.
Sounds pretty trippy. How does ketamine do that? How does it pull off this mind-bending act?
Well, it all comes down to NMDA receptors.
Okay.
Ketamine blocks those.
Right.
And those receptors are involved in learning memory and pain perception.
Okay.
This disruption of normal brain activity
Yeah.
leads to that dissociative state.
So it's like messing with the brain's wiring,
It's messing with the wiring
but in a very specific way.
in a very specific way.
Yeah, and I remember from my rotations that ketamine's pretty versatile.
Very versatile.
You can give it IV or IM,
IV or IM.
which is great for those times when you can't get an IV line in.
Yeah, think about kids,
Yeah, kids.
trauma patients,
Trauma patients.
agitated patients.
Oh, yeah. And here's another unique thing about ketamine.
Okay, what's that?
It stimulates the cardiovascular system.
It does. What?
So it increases heart rate, blood pressure, and cardiac output.
All of that.
This makes it a good choice for patients in shock or those with low blood pressure.
Exactly.
So it's like a shot of adrenaline to the heart.
Yeah, it is.
But hold on, didn't we learn that ketamine was bad for patients with head injuries?
I know, this is where it gets tricky.
Because it increases intracranial pressure. Right, that's what we used to think.
Oh,
But evidence is showing that when used carefully,
okay.
it may not significantly increase intracranial pressure.
So maybe ketamine's getting a bit of a bad rap.
Maybe a little bit.
And before we move on, I have to mention,
Okay?
it's a potent bronchodilator,
It is.
which makes it a
Yeah.
great choice for asthmatic patients.
That's right, another perk.
So ketamine is this
Yeah.
multifaceted drug
Very multifaceted.
with a lot of interesting properties.
Very interesting.
Okay, time for another big player in the anesthetic world.
Okay, who's that?
Etomidate.
Etomidate.
What's its claim to fame?
Well, Etomidate is known for its hemodynamic stability.
Okay.
It has minimal effects on the cardiovascular system.
So minimal effect.
Minimal effects, which makes it good for
Yeah.
patients with unstable blood pressure.
Okay, so it's good for those
Yeah.
heart-challenged patients.
Yeah.
That's important. But how does it work? It's magic.
So it mimics the effects of GABA, like the other drugs we've talked about.
Another GABA fan.
That's right.
But it can also cause...
Right, but there's a catch.
What's the catch?
It can cause those weird myoclonic jerks during induction.
Like what?
It's almost like the patient's having a mini seizure,
Oh.
but it's usually harmless.
Oh, phew, as long as it's harmless. Are there any downsides to using Etomidate?
The main concern is the effect on the adrenal glands.
Okay.
So Etomidate suppresses the production of cortisol and aldosterone,
Right.
which are hormones that regulate stress and fluid balance.
So it's messing with the body's stress response.
It is.
That doesn't sound good.
It's not ideal.
Especially in really sick patients.
Right. Those who are already under a lot of stress.
Exactly.
Okay, so we want to avoid using that one too much.
Yeah, prolonged use, we want to avoid that.
Makes sense. We don't want to add insult to injury. All right, let's move on to what I feel is like the superstar
All right.
of the IV anesthetics.
Who's that?
Propofol.
Ah, Propofol, the popular one. I feel like this is the one everyone's talking about.
Everyone's talking about it.
What makes it so popular?
Well, Propofol
Yeah,
is a workhorse in the OR because it has a lot going for it.
I can imagine, yeah.
First, it boosts GABA.
Another GABA fan.
Yeah, another one.
Oh my gosh, they love GABA.
They love GABA, but this one
Right.
does it in its own unique way.
Okay, so what's special about its mechanism?
So Propofol essentially helps a GABA work more efficiently,
Okay.
leading to stronger inhibition of nerve cells.
So it's a GABA enhancer.
It enhances GABA.
But I have a question about its formulation.
Okay.
It's an oil in water emulsion.
It is.
Does that mean people with egg allergies can't have it?
That's a good question.
Yeah.
So it actually contains egg lecithin,
Okay.
but most egg allergies are to the protein in egg whites,
Right.
not to lecithin.
Okay.
So unless someone's specifically allergic to lecithin, they're usually fine.
Gee, that's good news for egg lovers.
Good news.
But let's get back to what makes Propofol so popular.
The deal with its pharmacokinetics.
Rapid onset,
Okay.
rapid recovery.
Ah, so it works quickly and wears off quickly.
That's right.
Perfect for.
Perfect for outpatient procedures.
Yeah.
When you want folks up and about.
Yeah, you want to get them in and out
Yeah.
as quickly as possible.
Yeah, exactly.
Makes sense. It can't be all sunshine and rainbows, though, right?
Yeah.
What are some downsides?
Well, like most anesthetics,
Mm.
it can lower blood pressure
Okay.
and suppress breathing.
Right.
So monitoring is key,
Yeah, you got to keep an eye on those vital signs.
for sure.
But you mentioned some other interesting properties.
I did,
So,
too.
yes.
Tell me more.
So Propofol is a multitasker.
Okay, I like it.
It's got anticonvulsant properties,
I mean,
meaning it can help manage seizures.
okay.
It seems to have neuroprotective effects,
Oh,
potentially protecting the brain from damage.
wow.
And it can even reduce nausea.
Wow. That's a lot of hats
It is a lot of hats.
for one drug to wear.
It is.
Putting you to sleep, protecting your brain,
Yeah.
keeping seizures at bay,
But-
preventing nausea.
all of it.
It's like a superhero of anesthetics.
It is.
But there's one more thing.
One more thing.
We have to mention
Right.
this rare but serious complication
Right.
called Propofol infusion syndrome.
Yes.
What is that?
It's characterized by metabolic acidosis,
Oh.
muscle breakdown,
Oh, no.
cardiovascular collapse.
That sounds bad.
Yeah, it's not good.
Is it common?
Most often seen with prolonged high-dose infusions,
Oh.
especially in younger patients.
So something to be aware of.
Definitely something to be aware of.
Okay, and lastly, is there anything special about dosing Propofol?
Yes, so age and body size play a role.
Okay.
Elderly patients and those with lower body mass may need smaller doses
Right.
because of differences in how their body handles the drug.
All right, I'm taking notes. Age,
Yeah.
body size, watch out for Propofol infusion syndrome.
Keep that in mind.
Got it. Now let's talk about the new kid on the block, Fospropofol.
Fospropofol, all right.
What's the scoop on this one?
It's a prodrug of propofol,
Okay.
so it's not active until it's metabolized in the body.
A prodrug, that's
Yeah,
like
yeah.
it's like a secret agent that transforms.
It transforms.
What's inside the body.
Exactly.
Interesting. And because it needs to be converted,
Right.
it has a slower onset and recovery
Slower onset and recovery.
compared to regular Propofol.
That's right.
So it's more of a slow burn.
It is.
What's the advantage of that?
Well, it seems to have a better safety profile,
Okay.
less pain on injection,
Okay, less pain?
and lower risk of bacterial growth.
Okay.
So
So it's like the gentler, more refined cousin of propofol.
Kind of like that, yeah.
Yeah. And it seems to be finding a place for itself
Right.
in those conscious sedation procedures.
Like endoscopies.
Yeah, like endoscopy.
Uh-huh.
Okay, so it's like the perfect drug
Yeah.
when you need him to be relaxed,
Relax.
but still be able to
Yeah,
respond.
onto commands.
Yeah, exactly. It's a nice addition to our anesthetic toolbox.
Another tool in the toolbox.
All right, so we've covered a lot of ground.
We have
You know, we've got all these different intravenous anesthetics,
lots of options.
each with their own personality and their own quirks.
Right.
But how do we choose the right one for a given patient?
That's a great question. It's like picking the perfect wine.
Yeah, it's like picking the perfect wine for a 5-course meal.
Exactly.
So many options. How do we do it?
That's where that clinical judgment
Right.
experience
Yeah.
comes in.
But luckily, we have some guidelines
We do.
to steer us in the right direction.
Yeah.
So you mean like a cheat sheet
Kind of like a cheat sheet.
for anesthesiologists?
That's right.
Tell me more.
So your source material actually has a great table
Okay.
outlining different clinical scenarios
Right.
and suggests the preferred intravenous anesthetic
Ooh, okay.
for each one.
All right, so let's walk through a couple of examples.
Let's do it.
Okay, let's put our knowledge to the test.
Right.
Imagine you're in the ER with a trauma patient who's in shock.
Okay.
Their blood pressure is plummeting and they need to be intubated.
Right.
What would be your go-to induction agent?
What would you choose?
Okay, let me think.
Yeah, think about it.
We need something that will boost their circulation
Okay.
and keep their airway open.
Okay.
And if they have any lung issues, we don't want to make those worse.
You got it.
And so, based on what we've learned, I'd say
What do you think?
ketamine.
Ketamine, that's a great choice.
Yeah.
It stimulates the cardiovascular system, provides bronchodilation, and doesn't worsen lung function.
Nailed it.
You got it.
Okay, what about a patient coming in for a quick outpatient procedure,
Oh,
like a colonoscopy?
right.
What would we choose for them?
So in that case, you'd want something with a rapid onset and recovery.
Okay.
So they're not groggy for hours afterwards.
It's something like Propofol, exactly. Yeah. It's like the anesthetic equivalent of a quick nap.
It is.
Okay, one more scenario.
All right, one more.
We've got a patient with really unstable blood pressure
Okay.
who needs to be intubated.
All right, unstable blood pressure.
That's the best option.
So you want something that won't drop their blood pressure any further?
Right, so we'd avoid anything that causes hypotension.
Exactly. And the drug that fits the bill is
Oh, was it Etomidate?
Etomidate. You got it.
Yeah.
It has minimal effects on blood pressure and heart rate,
Makes sense.
making it the safest option
Yeah.
for those patients.
Right, I'm starting to feel like a pro here
Yeah.
at choosing anesthetics. But before we get too cocky, are there any other factors we need to consider
Of course.
besides the immediate clinical situation?
So you got to think about
Yeah, what else do we have to think about?
drug interactions,
Oh, right.
terogenic effects,
Parodygenic effects.
especially in pregnant patients or those on multiple medications.
Yeah, good point. We don't want to accidentally create a pharmacological cocktail
Yeah,
that
fair.
harms the patient.
Right.
Looks like we got to check those drug interaction charts
You got it.
and pterogenicity databases before we start pushing drugs.
Always better to be safe than sorry.
Absolutely.
A
Okay, I think we've covered a ton of information here about intravenous anesthetics,
lot of information.
from how they work to their effects
Yeah.
on different organs,
Mm-hmm.
and how to choose the right drug for the right situation.
Exactly.
My brain is officially full.
I know it's a lot to take in.
Yeah, but it's crucial information for safe and effective anesthesia practice,
It is.
for sure. But let's switch gears now
All right.
and delve into another essential class of drugs
Okay, let's do it.
in our anesthetic arsenal,
What's that?
opioids.
Opioids.
These are the heavy hitters of pain management.
That's right.
They are.
So,
Yeah.
buckle up, everyone, because we're about to enter the world of opioid analgesia. We are. Welcome back to the deep dive. We're sticking with our journey through intravenous anesthetics, and now we're honing in on a class of drugs that are really at the heart of how we manage pain.
Opioids.
Yeah.
Opioids.
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 Yeah.
Those pain-relieving powerhouses.
But they come with some serious baggage.
Yeah, some baggage for sure.
We've got a mountain of info here about how they work their effects and all the things we need to be cautious about.
Definitely got to be cautious.
But before we get into all of that, let's start with the basics.
Okay.
How do these drugs actually relieve pain? What's the magic?
All right. So opioids work by binding to opioid receptors in the body.
Okay.
And you find those receptors throughout the nervous system and even in some peripheral tissues.
Okay.
When opioids bind to those receptors,
Yeah.
it triggers a whole cascade of events.
Okay.
And ultimately, it reduces both the perception and the transmission of those pain signals.
So they're like little keys.
Like little keys.
Fitting into specific locks.
Exactly.
And those locks control our pain experience. That's a great way to think about it.
Cool. And there are different types of opioid receptors, right?
Yeah, you've got your mu kappa delta and sigma receptors.
Mu kappa delta sigma. Okay.
Yeah. And each of those subtypes has its own unique effects.
Okay.
Which explains why different opioids have slightly different clinical profiles.
Oh, that makes sense.
Right.
So it's not as simple as just opioid meets receptor pain disappears.
Not that simple.
There's more to it.
There's more to it.
It's like a complex dance.
Yeah, a complex dance.
Between the different opioid molecules and the receptor types.
That's a great way to put it.
Okay. So depending on which receptor an opioid binds to
Right.
and how strongly, you get a whole range of effects.
A whole range. Yeah, pain relief, sedation, euphoria, slowed breathing, constipation. The list goes on.
It's a long list, so we've really got to be careful
We do.
about which opioid we choose and how much we give.
Absolutely.
Okay, let's focus on pain relief for a second.
Okay, pain relief.
How do opioids actually stop those pain signals that are screaming, ouch, to our brains?
Okay, so they work on multiple levels.
Okay.
At the spinal cord level,
Yeah.
opioids inhibit the release of those neurotransmitters
Okay.
that carry those pain signals up to the brain.
So they're blocking the signals at the source?
Blocking at the source, and they also
Oh.
activate those descending inhibitory pathways, which are basically the brain's natural pain control system.
So they're boosting the brain's own pain-fighting abilities, too.
Exactly, double whammy.
Double whammy. What about the different ways we can give opioids?
We have a lot of options there.
Yeah, like what?
We can give them IV, IM, or even directly into the spinal cord or the epidural space.
Oh, wow. Okay, so lots of different routes of administration.
Lots of routes, and the choice really depends on the situation, the type of pain, and how long we want that pain relief to last.
So we're customizing it to the patient's needs.
Customizing it, exactly.
Okay, but let's talk about pharmacokinetics. How do different opioids differ in terms of how quickly they work and how long they stick around?
Okay, so this can get a little complicated.
Yeah, I was afraid you were going to say that.
But one of the key concepts is context-sensitive halftime.
Context-sensitive halftime.
Yeah.
Okay, I'm pretty sure I should have learned that in pharmacology.
It comes back to haunt you.
But I probably forgot it. Can you remind me?
I can remind you.
Please.
So basically, it's the time it takes for the drug's concentration in the blood to decrease by half.
Okay.
After we stop an infusion.
Okay.
And it tells us how long the drug's effects will last.
Okay.
Especially after we've been giving it continuously.
Okay, so an example
Okay, an example?
would be if you're giving a patient fentanyl
Right.
through an IV for several hours during surgery.
Yeah.
That context-sensitive halftime is going to be longer
It will?
than if you just gave a single dose.
Exactly.
Okay, so the more you give and the longer you give it,
Yep.
the longer it takes to clear the body.
That's the idea.
Okay, and I'm seeing here that different opioids have different context-sensitive halftimes.
They do different halftimes.
Yeah, what's an example of that?
Okay, so remifentanil
Remifentanil, okay.
has a super short context-sensitive halftime.
How short are we talking?
About 3 minutes.
3 minutes? No matter how long you've been giving it?
No matter how long.
Wow, that's crazy. So it's perfect for those times when you need the effects to wear off really quickly.
Exactly, like at the end of surgery,
Yeah.
you want them to wake up quickly.
So remifentanil is like the anesthetic equivalent of a light switch.
Like a light switch on and off.
Yeah, just on and off super fast.
Exactly.
Okay, let's talk about what happens to these drugs once they're inside the body.
All right, let's talk about metabolism.
How are they broken down and eliminated? I'm guessing the liver's involved?
You're right, the liver is involved in most cases.
Okay, as usual.
But there are some exceptions.
Like,
Remember remifentanil?
oh yeah, the light switch one.
The light switch one, it's actually broken down by enzymes in the blood and tissues,
Oh, interesting.
not by the liver,
Okay.
which makes it a safer choice for patients with liver disease.
Ah, because it bypasses the liver.
It bypasses the liver.
Very cool. But what about the opioids that DO rely on the liver?
Right.
What do we have to think about there?
Well, we gotta be careful about drug interactions and metabolites building up,
Okay.
especially in patients with liver or kidney problems.
Yeah, that makes sense. So like an example.
Okay, so morphine is metabolized into a compound called morphine 6-glucuronide.
Morphine 6-glucuronide.
Okay, which can hang around
Oh no.
and cause prolonged effects in patients with kidney issues.
So maybe not the best choice for
Right.
those patients.
Try to avoid it if you can.
Okay, noted.
Yeah.
But what about meperidine?
Meperidine. Oh, yeah.
It's metabolized into something toxic, right?
Yeah, that's concern.
Okay.
So meperidine breaks down into normeperidine,
Normeperidine.
which can accumulate
Hmm.
and cause seizures, especially in patients with kidney problems.
Oh, no. So meperidine's not really used anymore.
It's kind of fallen out of favor, yeah.
Yeah, for routine pain management.
Yeah, not really the go-to anymore.
Okay, meperidine filed under use with extreme caution.
Extreme caution for sure.
But let's move on from metabolism and talk about the effects of opioids on different organs.
Okay. Effects on organs.
We all know they can slow down breathing, but what else do we need to be watching out for?
So opioids can do a number on the body.
Yeah, like what?
We can see bradycardia, which is a slowing of the heart rate,
Okay.
or even hypotension,
Hypotension, which is
low blood pressure.
low blood pressure. Okay.
They can also suppress cough reflexes and even cause chest wall rigidity,
Oh, wow.
making it harder to breathe.
So we've got to be really on top of monitoring our patients.
Absolutely close monitoring.
Yeah, when they're on these drugs. Yeah. And what about the brain? Do they affect the brain besides just pain relief?
They definitely can.
Okay, how so?
Well, they can cause sedation.
Right, that sleepy feeling.
That sleepy feeling, yeah.
Okay,
Yeah.
that feeling of well-being.
Feeling good,
Right.
but sometimes even dysphoria,
Dysphoria.
which is that feeling of unease.
Oh, that's not good. So it could be a mixed bag.
Yeah, a mixed
Yeah.
bag of mental effects.
And speaking of mixed bags,
What about?
nausea and vomiting.
Oh, yeah.
That often comes with opioid use.
Right, nausea and vomiting are pretty common.
Yeah, is there any way to avoid that?
Unfortunately, not always.
Okay, why does it happen?
So it's thought to be caused by stimulation of the chemoreceptor trigger zone
Okay,
in the brainstem.
which is...
That's the part of the brain that detects toxins and triggers vomiting.
And the brain thinks the opioid is a poison
It thinks it's a poison.
and tries to get rid of it.
Exactly.
Makes sense, but definitely not fun for the patient.
How fun.
I'm guessing we have some anti-nausea meds
We do.
to combat that, though.
We use them a lot.
Okay, good. But I'm seeing this other term in the notes. Opioid-induced hyperalgesia.
Ah, hyperalgesia.
What is that?
That's a bit of a paradox.
Okay.
So it basically means that prolonged exposure to opioids can actually increase pain sensitivity.
Wait, what?
Yeah, it's like the pain reliever makes the pain worse.
That is so counterintuitive. How does that even happen?
We don't know for sure, but it seems to involve some changes in the nervous system
Okay.
and how it processes pain signals.
So it's like the body is fighting back
It's fighting back.
against the opioid.
Exactly.
It's like enough is enough.
That's right.
Okay, so that's why it's so important to use these drugs carefully
Very carefully.
and consider other pain management strategies whenever we can.
Absolutely.
We don't want to get stuck in that vicious cycle
New vicious cycles.
of more pain, more opioids.
Nope.
All right, and what about the opioid-induced constipation? Seems like every patient I've ever seen on opioids
Yeah.
is also constipated.
It's very common.
Why is that such a common problem?
So opioids bind to receptors in the gut.
Okay.
And this slows down gut motility.
Gut motility means...
Those wave-like contractions that move things along.
Oh, right.
So the slowdown leads to constipation.
So it's like hitting the pause button
Like hitting pause.
on the whole digestive system.
Exactly.
Ugh, that's not good. Is there anything we can do about that?
Luckily, yes.
Okay, what is it?
We have medications called peripheral opioid antagonists,
Okay.
like methylnaltrexone.
Methylnaltrexone.
And those can block the effects of opioids in the gut
Oh,
without messing with the pain-relieving effects in the brain.
so they just target the gut,
Target the gut,
but not the brain.
not the brain.
That's pretty cool. These drugs are a game changer.
They can be a real game changer.
Yeah, for managing that opioid-induced constipation.
And improving quality of life.
Yeah, absolutely. Okay, we've talked a lot about the downsides.
Yeah, we have.
But are there any times when opioids are really the best option?
There are.
Okay, like when?
So they're still the gold standard
Okay.
for acute severe pain, like
Like, yeah.
after surgery or
Yeah.
trauma. They can also be helpful for chronic pain,
Right.
but we have to be really careful and weigh those risks and benefits.
Yeah, so it's all about choosing the right tool for the job
Right tool for the job.
and being mindful of the potential downsides.
Absolutely.
Okay, before we move on to other pain management strategies,
Okay.
Let's just recap some key points about using opioids safely.
Let's recap.
What are the most important things to remember?
All right, so first, we got to be aware of drug interactions.
Okay, drug interactions, like,
Especially with other medications that depress the central nervous system.
okay, like what kind of medications?
Think benzodiazepines.
Oh, yeah, right. Benzodiazepines. We talked about those.
We did.
They can cause sedation and respiratory depression.
Exactly.
So double the depressants, double the trouble.
Double the trouble.
Okay, what else?
So we always need to adjust doses
Right.
for patients with kidney or liver problems because those organs are key for processing and clearing those opioids.
So we're basically customizing the dose
Customizing the dose.
to the patient's ability to metabolize the drug.
Exactly.
Okay, what else?
And we need to stay vigilant for signs of opioid-induced hyperalgesia.
Right. That paradoxical effect.
That paradoxical effect.
So if the pain's getting worse,
Yeah.
even though we're giving more opioid,
That's a red flag.
we need to think about other strategies.
Absolutely.
Okay, excellent takeaways
Good takeaways.
for using opioids safely. Now let's explore a class of drugs that might help us avoid opioids altogether. In some cases,
Who were we talking about?
KOX inhibitors.
KOX inhibitors, all right.
Tell me about these pain-fighting molecules.
So KOX inhibitors,
Like, what are some examples?
like ibuprofen,
Okay, ibuprofen.
naproxen,
Naproxen. Yeah, okay.
they work by targeting enzymes called cyclooxygenase enzymes.
KOX enzymes.
KOX enzymes, exactly.
And these KOX enzymes make
Prostaglandins,
prostaglandins.
those pesky little chemicals that cause pain and inflammation.
Yeah. So they're attacking the inflammation at the source?
At the source.
Very clever.
Yeah.
But you mentioned that there are different types of KOX enzymes.
Different types, yeah.
What's the difference between KOX1 and KOX2?
All right, so KOX1
Okay.
is always there in the tissues.
Oh, so it's like always on.
Always on, and it helps with those normal bodily processes like protecting the stomach lining
Okay.
and promoting blood clotting.
Okay, so it's kind of a good guy.
KOX1 is the good guy, and
Yeah.
KOX2 is
It's a-
produced mainly during inflammation.
Oh, so it's like
Yeah.
the body's emergency response enzyme.
Exactly.
So it's the bad guy.
The bad guy.
KOX1 is good. KOX2 is bad.
That's a good way to remember it.
Okay. And this is important
It is.
because it led to the development of drugs that selectively target KOX2,
That's right. Like
like celecoxib.
celecoxib. Okay.
Yeah.
So these selective KOX2 inhibitors
Yeah.
are like
They're like
precision-guided missiles.
precision-guided missiles.
It's only going for the bad guy.
That's a great analogy.
KOX2.
But they're leaving the good guy, COX1, alone.
Exactly.
Makes sense.
Yeah.
So the idea was that these selective KOX2 inhibitors would have fewer side effects
That was the hope.
compared to the older COX inhibitors
Right.
that block both.
Both KOX1 and KOX2.
Makes sense. What are the side effects we're trying to avoid?
So one of the biggest worries with those non-selective COX inhibitors is their effect on the stomach,
Okay, the stomach, what do they do?
because they block KOX1,
Right. Which is protective.
which is protective.
Yeah.
They can increase the risk of ulcers and bleeding.
So they're good at fighting pain and inflammation, but they can also give you a stomach ulcer.
Yeah, that's the trade-off.
Yikes, that's a serious trade-off.
It is.
So then the selective KOX2 inhibitors came along.
They did.
And everyone was excited because they were supposed to be safer.
Safer for the stomach.
But it turns out
It turns out
they have their own risks too.
they do.
What's the catch with the COX2 inhibitors?
So studies have shown that they might increase the risk of heart attacks and strokes.
Oh no, why? Why would they do that?
So the thinking is that by blocking KOX2,
Yeah,
they shift the balance of prostaglandins
okay.
in a way that favors blood clotting.
So they protect the stomach but potentially harm the heart.
It's a balancing act.
Yeah, it's a tough balancing act.
Yeah.
But where does aspirin fit into all of this?
Aspirin's a unique case.
Yeah.
It blocks KOX1,
Okay.
but it does so irreversibly.
Irreversibly, okay.
Meaning its effects last for the entire lifespan of a platelet,
Which of how long?
about 7 to 10 days.
So it's a long-lasting KOX1 assassin.
You could say that.
Yeah. So that's why it's great for preventing blood clots.
Exactly.
But we got to be careful using it before surgery
Yeah.
because of that bleeding risk.
That bleeding risk.
We don't want them bleeding out on the operating table.
We don't want that.
Makes sense. But what about acetaminophen?
Acetaminophen's a bit of a mystery.
Yeah.
It's got some weak KOX inhibiting effects, but its main mechanism seems to be in the central nervous system.
Oh, interesting. So it works differently.
It works differently. So we think it works by reducing the production of certain pain signaling chemicals
Okay.
in the brain and spinal cord.
So it's more of a central pain buster.
Yeah, central point
So
buster.
rather than a peripheral inflammation fighter.
Exactly.
Interesting. Our notes mention something about acetaminophen toxicity, though.
Yeah, we got to talk about that.
Yeah, that sounds a little alarming.
It is something to be aware of.
Okay, what's the deal with that?
So acetaminophen's generally safe
Okay,
at recommended doses.
right.
But if you go over that limit,
Yeah.
it can be dangerous.
Okay, how so?
So it's processed by the liver,
Okay.
and one of its metabolites
Yeah.
is toxic to liver cells.
Oh, no. So too much of
You
it
know how much is bad news?
is like an overload for the liver.
It overloads it, and that can lead to liver failure
Oh, wow.
if it's not treated quickly.
That's serious. So we got to stick to the recommended doses. And avoid taking multiple medications
Right.
that contain acetaminophen.
Definitely.
Okay, acetaminophen, effective pain reliever, but potentially dangerous
Yeah, you got
in
it.
high doses.
Wow.
Got it. Okay, now let's talk about a couple of drugs that I've been hearing more and more about
Okay.
for pain management.
Who are we talking about?
Gabapentin and pregabalin.
Gabapentin and pregabalin, all right.
What's their story?
So they were actually developed as anti-seizure medications,
Oh, interesting.
but it turned out they were good at treating pain.
Oh, cool. So another accidental drug discovery.
Yeah, one of those happy accidents.
I love those.
Yeah.
But how do they actually work?
So they work in a unique way.
Okay.
They target voltage-gated calcium channels.
Okay, remind me what those are.
So those channels play a role in the release of neurotransmitter.
Neurotransmitters.
And some of those are involved in pain signaling.
Right. Okay, can you remind me what neurotransmitters are again? It's been a while.
Sure, so neurotransmitters are basically chemical messengers that allow nerve cells to communicate.
Okay.
And some of those neurotransmitters, like glutamate and substance P,
Yeah.
are involved in transmitting pain signals.
Okay, so these drugs are blocking the release of those pain signaling chemicals.
They're blocking the release, exactly.
Interesting. So this makes them especially helpful for neuropathic pain,
Exactly.
which is
Pain that's caused by damage or dysfunction of the nerves.
right, and that type of pain can be really hard to treat
Very difficult to treat.
with traditional pain relievers.
Yeah, the usual stuff doesn't always work.
Interesting. So they're like specialized pain relievers for a very specific type of pain.
That's a great way to think about it.
Are there any downsides to using them, though?
Of course, there are always downsides.
Yeah, what are they?
They can cause some side effects like dizziness, sedation, weight gain,
Okay.
and we got to be careful with the dosing,
Especially in,
especially in the elderly.
right, they're more sensitive to medication side effects.
Exactly.
But overall, it sounds like these are useful
Very useful.
additions to our pain management toolbox.
Okay. Another tool in the toolbox.
Yeah, they give us more options for treating that tricky neuropathic pain
They do.
that doesn't always respond to other meds.
Absolutely.
Speaking of having more options, it's important to remember that medications are only one piece of the pain management puzzle.
That's right.
We can't forget about those non-pharmacological approaches.
The non-drug options.
Yeah, they could be just as important.
If not more important,
Yeah.
sometimes.
What are some examples of those?
So you've got physical therapy, massage, acupuncture,
Right.
even psychological therapies like cognitive behavioral therapy.
Yeah, so it's about taking a holistic view
Holistic view.
of pain management.
That's right.
We got to look at the whole patient, not just their symptoms.
The whole patient.
We need to address both the
The physical.
and the psychological aspects of pain.
Couldn't have said it better myself.
That was quite a journey through pain management.
There was.
We covered opioids, COX inhibitors,
Yep.
even those gabapentinoids.
The gabapentinoids.
But before we wrap up this whole deep dive into intravenous anesthetics,
Yeah.
we've got a few more interesting things to explore.
A few more tidbits.
Welcome back to the deep dive.
Oh.
We've made it to the final leg of our intravenous anesthetic adventure.
That's right. We've covered the basics, the must-knows.
Yeah.
But, there are always those little details.
Those clinical pearls.
The clinical pearls, yeah, that can really make a difference
Yeah.
when you're actually at the bedside.
Okay, so what pearls have you got for us?
All right, let's start with thiopental.
Gabapentin? Oh, yeah, the barbiturate.
The barbiturate. Remember we talked about what happens if you accidentally inject it into an artery?
Oh, yeah. That's not good.
Not good. That super alkaline solution can really damage those blood vessels.
Yeah, it's like putting diesel in a gasoline engine.
Exactly. Not a good situation.
So what happens if we find ourselves in that situation?
All right, so your notes actually mention some specific steps
Okay.
for managing that.
Okay, I'm ready. Give it to me.
Okay, so the key is to act fast.
Time is of the essence. What do we do?
First, you want to inject a vasodilator, like papaverine,
Okay.
directly into the artery.
Okay, so right into the artery.
Right into the artery to try to counteract that vasospasm.
Okay, so it's like opening up the floodgates.
Yeah, opening up the floodgates
To restore circulation.
to get that blood flowing.
Okay, then what?
And then you'd start heparin.
Heparin, the blood thinner.
The blood thin. Why are we using that?
Why are we using that?
Well, to prevent thrombosis.
Okay, right, because...
Because thiopental
Yeah.
can damage the lining of that artery, making it more likely to clot.
Right, so we're trying to keep that blood flowing
Keep it flowing.
smoothly
Right.
and prevent any blockages.
Exactly.
So it's like damage control for the blood vessel,
Damage control.
trying to prevent further complications.
That's the idea.
Makes sense. Is that it, or is there another step?
One more step.
Okay, what's the last step?
A sympathetic block.
Sympathetic block.
So this involves injecting a local anesthetic around the nerves that control those blood vessels.
Oh, so we're blocking the signal
Not the signals.
that tell the blood vessels to constrict.
Exactly.
Okay.
So that helps to further dilate those vessels.
Yeah, and get that blood flowing again.
Get that blood flowing.
It's a three-pronged approach
Three-pronged approach.
to really minimize the damage.
To minimize the damage.
Wow, talk about an all-hands-on-deck situation.
It is.
Okay, what other clinical pearls have you dug up?
All right, let's talk about drug interactions.
Oh, drug interactions, always got to be mindful of those.
Always got to be mindful.
Okay, what do we have here?
So your material mentions a tricky interaction between HIV medications and anesthetics.
HIV meds and anesthetics.
Yeah. How do those two worlds collide?
How do those connect?
So certain HIV protease inhibitors,
Okay.
like indinavir, nalfenavir, ritonavir,
Okay.
can increase a patient's sensitivity to midazolam.
Oh, so patients on these HIV meds might experience stronger effects from midazolam than we'd expect.
Than we'd expect, which could be dangerous.
Yeah, that could be dangerous.
So we definitely need to be aware of that interaction and adjust our doses accordingly.
Right. We might need to use a much lower dose
Much lower dose.
of midazolam
Midazolam.
to get the effect we want without
Right.
causing too much sedation or respiratory depression.
You got it.
Okay, HIV protease inhibitors plus midazolam
Yeah.
equals potential trouble.
Equals trouble.
Got it. Any other drug interactions we should be watching out for?
Another one that comes up is the combo of meperidine and MAOIs.
Meperidine and MAOIs, those are the...
Or monoamine oxidase inhibitors.
Right, the antidepressants.
The antidepressants, yeah.
Okay, what's the problem with mixing those two?
So this combo can lead to a really serious reaction.
Oh, yeah, quiet.
We're talking hypertensive crisis, high fever coma,
Oh,
even respiratory arrest.
wow, that's a recipe for disaster.
It is.
Okay, so meperidine and MAOIs are a definite no-no.
Big no-no.
But what about other opioids? Are they safe to use with MAOIs?
So luckily, other commonly used opioids like morphine and fentanyl
Okay.
don't have that same dangerous interaction.
Oh, okay, so those are safer options.
Safer options.
If a patient who's on an MAOI needs an opioid.
Exactly.
Okay, that's really important information.
It is.
It's like a mental checklist.
Yeah, a checklist.
We need to run through every time we're considering opioids for a patient.
Absolutely.
Opioid selection really matters when it comes to these drug interactions.
It really does.
Okay, anything else we need to cover before we wrap up this deep dive?
Let's circle back to that idea of choosing the right anesthetic.
Okay, choosing the right anesthetic
Right. Yeah.
for the right situation.
For the right situation.
Yeah.
Your notes actually have a case
Oh, a case.
that illustrates this point.
I love cases. Lay it on me.
All right. So we have a patient with colon cancer
Okay, colon cancer.
who's undergoing surgery for liver metastases.
Liver mets bit. Okay, so pretty complex case.
It is a complex case.
What's the anesthetic challenge here?
So this patient develops severe metabolic acidosis.
Oh, metabolic acidosis.
Surgery.
That's not good.
And the question is, what's the most likely cause?
Okay, so metabolic acidosis. What are the patient's risk factors here?
So he has a history of ileal conduit surgery,
Right.
diabetes,
Okay, diabetes.
heavy smoking,
Right.
and a family history of malignant hyperthermia.
Oh, wow. And he also received a blood transfusion,
Right, during the surgery.
which can contribute to acidosis.
That's right.
So we've got a lot of potential culprits here.
A lot of
What
possibilities.
anesthetics did he receive?
So he got morphine, midazolam, oxygen, and a propofol infusion.
Propofol infusion? Sounds familiar.
Why does that sound familiar?
Didn't we talk about a rare but dangerous complication associated with propofol?
We did propofol infusion syndrome,
Propofol infusion syndrome.
characterized by metabolic acidosis, muscle breakdown, cardiovascular collapse.
Oh, so could that be what's going on here?
It's definitely a possibility.
Yeah.
Especially since he was on that Propofol infusion for a
Right.
long time during surgery.
Well, we can't rule out the other causes either,
We can't rule out those other causes.
like the diabetes,
diabetes.
the blood transfusions.
Blood transfusion.
So we need more information to figure out the exact cause.
We need more information.
But this case really highlights how important it is to be aware of those rare but potentially serious complications.
Absolutely. Vigilance is key.
Yeah, got to be on your toes
On your toes.
and monitoring those patients closely.
Close monitoring is essential.
Okay, I think we've officially squeezed every last drop of knowledge
I think we have
out of these materials.
squeezed it all out.
We've covered so much,
We have
from how these drugs work
the mechanisms,
to the clinical pearls
the pearls,
to the potential pitfalls.
the pitfalls.
It's been quite a journey
It has.
through the world of intravenous anesthetics.
From putting patients safely to sleep
Right.
to managing their pain,
Yeah.
navigating those drug interactions.
Yeah. These drugs are really powerful.
Powerful drugs.
They play a vital role in modern medicine.
Absolutely vital.
But you know what they say?
What do they say?
With great power comes great responsibility.
Couldn't agree more.
As medical professionals,
Yeah.
we have a responsibility
You do.
to understand these drugs really well.
Thoroughly.
Yeah, and use them wisely
Obviously.
to ensure the best possible outcomes for our patients.
Well said.
And to all our listeners out there, thank you so much for joining us on this deep dive
Thanks for joining us.
into the world of intravenous anesthetics.
A fascinating world.
We hope you've learned some new things and feel inspired
Inspired.
to keep exploring this ever-evolving field,
It's always changing.
this pharmacology.
Always something new to learn.
Until next time,
Until next time.
stay curious, stay informed, and keep those brains buzzing.
Keep learning.
And remember, if you're ever unsure about which anesthetic to choose,
Yeah.
just ask yourself,
What would...
what would the deep dive host do?
That's right. We're always here to help you navigate the complex world of medicine. So long and happy anesthetizing.